radionuclide one is at least 99 that is used for the thyroid scan, and second injection is of the system image. We acquire different static image and then subtract one image from the other, and at last result is the exact localization of the parathyroid adenoma. Sometimes we have to use the SPECT CT, and this one is the sometimes we may have the surprise in the form of multiple parathyroid adenoma rather than a single. So this is the SPECT CT image that depicts multiple with bright spot and the small parathyroid adenoma on the both sides as well as the ectopic parathyroid adenoma. Sometimes the SPECT CT or the systemic scan is not 100% accurate, and that may be falsely negative in few cases. That is because of the overexpression of the big glycoprotein, so that system will get washed out from the gland. And another issue is the localization of the parathyroid. Instead of normal position, this may be ectopic parathyroid localization. So we image from cervical region up to the mediastinum of the heart region, so entire spectrum of the ectopic parathyroid adenoma can be done. So if you look at the image, 60% of paraesophageal, the tracheesophageal group, sometimes the 1% approx. In case of undescended cervical region, 4% are around the carotid sheath, and sometimes 10% are found approximately in the intrathyroid, and go lower down, sometimes may 5% in the anterior mediastinum. And so this is the. So if you are not able to diagnose or the system is falsely negative, then we can go for the F18 choline. The first we are doing the imaging with the SPECT CT, that's we also know as gamma camera, because of the sometimes poor resolution or the early washout of system may be negative. So we have to increase the sensitivity, that can be increased by the 18F choline. And this is the PET CT F choline PET CT that shows the localization of the parathyroid adenoma. Another additional investigation we can do use of the 4D CT scan in case of parathyroid adenoma. So usually, typically in case of polycontrastate parathyroid adenoma, the hypodense to the adjacent thyroid tissue, we give the contrast across the arterial phase, and they brighten and become approximately homogeneous. And then there is the washout in the delayed phase. So this technique will help in localization, especially in patients with multilobular goiter or multiple small tissues there in parathyroid adenoma of approximately 2 to 4 mm. So we combine 4D CT with PET CT and use the radio trace in the form of F choline PET CT. So this technique helps in localization of very small. Sometimes the patient may present to the clinician not directly as a diagnosis of parathyroid adenoma or the late PTH level. Sometimes the patient may present with unrelated symptoms, such like that this patient was presenting with a diffuse bony pain. MRI was done, and MRI was suggestive of multiple altered signal intensity, suggestive of some bony metastatic disease. But when we do the FDG PET CT, there is an ectopic tissue in the retrosternal region, and to confirm it's a parathyroid adenoma, we use the systemic scan. And with the multiple lytic lesions, these are the suggestive of brown tumor manifestation of the parathyroid adenoma. So if we combine, we have the multiple investigations for the parathyroid adenoma in the form of ultrasound, nuclear medicine, and 4D CT. So if we combine all these three in a sequential manner, definitely the sensitivity will be raised to a greater extent, and we have a greater localization and minimal incision to remove for the parathyroid adenoma. This article shows the utilization of combination of different modalities, but to the CT, there is the ectopic adenoma localization with the vascular plus, and then the F choline PET CT that shows the ectopic parathyroid adenoma. So after the parathyroid adenoma, second part is the localization or diagnosis of the paraganglioma. As you know, paraganglioma are the neuroendocrine tumor that can be located in the head, neck, thorax, and the abdomen. These are the two different places. First is the F-DOPA, and second is the gallium locus scan done in the same patient that shows the localization of the parajugulum with the paraganglioma. So help in the excision of the tumor. Then second, if there is a metastatic disease, unresectable disease, you can try with the alpha therapy as well as the PRRT therapy that can be labeled with the lutetium-177, and then if unresponsive, then second the targeted alpha therapy that can be used. So this is the example of the baseline PET-CT gallium nitride, and this is after the active therapy. This study is conducted in England, but and officially published in the European Journal of Nuclear Medicine. Which we can show that the bright spots which are the metastatic disease completely visual after the active nuclear. Now third point is the localization. In case of pancreas, insulinoma are the quite rare tumor and very difficult to localization, and the surgical excision is the only treatment for this to get relief from the patient. Patient multiple times present multiple episodes of hypoglycemia. This is the patient eventually referred to us from the Rohtak itself, because the conventional investigation people they see CTMR which not able to localize the actual spot of the insulinoma. We do the gallium level extending form. This is a basically GLP receptor analog, and then the whole body scan water, and this is the exact site of the localizing insulinoma. So patient undergo the excision of the tumor and becomes symptom free. So nuclear medicine has the specific investigation for the specific disease, and then accurate localization and excision of the tumor plays significant role in all these cases. This is the another case of insulinoma in which there is ectopic insulinoma. Usually the insulinoma are localized within the pancreatic gland, but these are localized in the lumbropancreatic group. This one is the ectopic insulinoma and with the metastatic disease. Although it's a benign, most of the time considered as a benign thing, but metastasis may happen in 1 to 2% cases due to the aggressive cause. And this is the ectopic insulinoma with liver metastasis. That's radionuclide using the gallium-68 GLP analog extending form. So not only in the diagnosis of the insulinoma on the table, we can help the surgeon in during the intraoperative period also for the localization with the help of gamma probe. So this is the patient with insulinoma in the body of the tail of the pancreas, and this is the intraoperative probe. We localize the adenoma with the number of radioactive counts in there, and the adenoma was removed, and then later on this is the post-excision state of later multiple times residual in the pancreas. So greatly helpful for the surgeon as well as the patient. Now from pancreas I am moving to the endocrine gland. This is the workhorse of nuclear medicine, taking FDG PET-CT. This is basically used in case of metastatic tumor as case of adrenocortical tumor. So the FDG PET-CT can in the initial staging, then response assessment, treatment monitoring. This is the regular we have discussed in the morning also. So basically this is the metastatic adrenocortical tumor. This is the primary tumor and these are the metastatic site. Then we can also help in localizing the diagnosing the ectopic source of the adrenocortical hormone secretion. This is the gallium level beta scan, and this is the abnormal focus in the liver, and this is the exact localization suggestive of ectopic source of the ACTH secretion. So the patient underwent those surgery, and then the removal lead to the relief of the symptoms. Another patient with the unusual site of the ectopic ACTH tumor, multiple site nodes amenable to the surgery. So we go forward with the PRRT therapy, that is the peptide receptor based radioligand therapy with the lutetium-177, and this is the baseline scan and with the post therapy scan. Then we know the resolution of the spores. So nuclear medicine not only help you in the diagnosis of condition, it provides you the exact localization, and if these are the non-operable things, we can help with the therapeutic potential also. So basically the new branch coming with the theragnostic, in which we first look, diagnose, and then treat with the radiation. Then gallium nitride also help in differentiating the functioning versus non-functioning adrenal adenoma. Every patient might have some accelerated hypertension with a 45-year-old male which has adrenal hyperplasia, and we have to look for any abnormal focus level of the ectopic secretion. This is the abnormal focal uptake, and then patient underwent surgery and adrenalectomy was done to relieve from the hypertension. Then move radio pressure, we are getting the gallium pentachlorophenol or the CXCR imaging, basically in the localization index of primary aldosterone producing adenoma. With the help of pentachlorophenol imaging, we are able to differentiate the unilateral aldosterone producing adenoma from the bilateral idiopathic hyperplasia versus non-functional adenoma. So rather than going imaging procedures such like adrenal venous sampling, prior to that pre-operatively non-invasively we can decide which adrenal gland needs to be removed and which is hyperplagic or which part of the adrenal gland is causing the symptoms. So that simply localized surgery can be restricted to that part rather than the exploration of the bilateral. This is the recent study which was published in the JAMA Network in 2023. It said accuracy of the gallium-68 pentachlorophenol for subtyping and diagnosis of the primary aldosterone with a ROC of approx 90 and 91%. This shows that the gallium pentachlorophenol has the ability to replace the adrenal venous sampling in case of primary aldosterone. So that's all from my side. We have the multiple radiotracer depending on the disease site and depending on the manifestation. We can go for the different radionuclide and help the surgeon in accurately localizing and minimizing the shorten the duration of the stay there. Thank you.
Thank you. I think this last presentation of aldosterone producing adenoma is really game changing, because prior to this, sir, it was difficult for us to prove that whether it is functioning adrenal adenoma, aldosterone producing adenoma, or hyperplasia. And going for adrenal venous sampling is itself as a difficult task. Not many centers are doing it. So I think last couple of slides are really interesting. The ROC curves which Dr. Dharmender had showed, and all the cases were, I think, very interesting and eye-opener for all of us, that taking the help of nuclear scans, you can be quite sure about what sort of patients you are dealing with. So, any comments from the house?
Dr. Malik, excellent presentation. Just few points I would like to make. In case of primary hyperparathyroidism due to MEN1, MEN2, secondary hyperparathyroidism and tertiary hyperparathyroidism, is there any role of localization with MIPI when we are contemplating excision and looking at all four glands because of the disease?
This is basically localization of the adenoma part. What you are talking, the adrenal, parathyroid hyperplasia. In this case, most of the time, system image scan is a negative one, as not shown, and this is the most common cause of the false negative or the negative system.
I think Dr. Dharmender's question is that in syndromic patients as well as in secondary tertiary hyperpara, when the planned surgery is going to be a 3.5 planned excision, what is the role of imaging? That is what is wanting to know.
Exactly. So, how can imaging add in this situation when we already are planning a complete neck exploration, looking at all four glands because of the kind of pathology involved?
Actually, this is scenario is clinically also very tough, but which the question Dr. Vivek has asked. Sometimes we have a patient who is having hypercalcemia. Calcium is 11, phosphorus is just around 1.8 and 2. PTH is highly raised, and we are dealing with a patient who is having hypercalcemia and PTH dependent hypercalcemia. And then, but we do not find anything on ultrasound. Parathyroids are normal. So, this is a practical confusion which comes up.
So, to answer Dr. Vivek's question, the only indication of doing imaging here is to rule out ectopic glands. Other than that, there is no indication. But it's nevertheless an important indication because we have found ectopic glands at times. Sometimes we find supernumerary glands also.
And moreover, we don't have to give any value to negative scans in these situations. For surgeons, at least, they should go ahead and operate irrespective of whether it's localized or not.
Yeah, that's Definitely, in case of hyperplasia, we have to go for the negative value, and then another form is the localization of the ectopic part, that there is apart from fourth and any external present on that.
So
That's the only
another point is about your insulinoma case where you showed a big insulinoma uptake. Was it not visible on CT scan because apparently you
Yeah,
showed a
that-
large
Yeah,
lesion?
patient had done the triphasic CT, and despite that, the radiologist was not able to localize it. You are talking about this case. If we go of the focal uptake, we go retrospective.
So what I can see is on even plain on contrast CT, you
This is
probably
the pancreatic tissue, and if you look retrospectively, there is subtle nodularity is there. So there is a very high chances of missing these findings in case of plain
so
CT.
probably first we have to have a relook radiological assessment, and then maybe we can add on this modality.
First one, if
Lot of times what I'm trying to say is the experienced radiologist can on a relook can really help again.
Yeah, definitely the radiologist can relook, but once have the focal uptake, and once he sends a positive, then we look for the retrospective. That is quite appreciable to see, and we will find yes, I have missed.
Yeah.
But if you're looking at the upfront,
So that's why I said relook from another radiologist probably sometimes can avoid extra imaging.
To answer Vivek sir's question in another perspective. So, as he has very rightly pointed out, this lesion is seen well on CT, so there is no reason why a radiologist would have missed it. But many times we do find multiple lesions in the pancreas. We have encountered this situation at times many times. Now, if there are 2, 3 or 4 enhancing lesions in the pancreas at various locations, all of them are showing similar features on contrast CT, and you don't know which is the culprit lesion that is actually causing the hypoglycemia. We have presented a few such cases in our CCR settings, and here is where examining plays a very critical role. So, in the recent case that we had, there were 4 neuroendocrine lesions, all 4 appearing similar on CCT, but examined localized only one lesion. That was excised, the patient was cured after that. So, that's another corollary to what.
So those other most probably they will be also neuroendocrine tumors. So
Yes.
won't they pick up? There won't be a false positive.
No, they don't pick
Scenario?
up. So here we have to understand that these lesions could be false positive on a Dotanox scan or a F-dopa PET. So F-dopa PET and Dotanox PET are going to show uptake in all 4 lesions. But Xendin will show only in the culprit lesion which is producing the injury.
so that's why it's specific for GLP receptor,
Right.
specifically high expression location.
So Dr. Samir has seen one very interesting case. He's published it also some years ago, and this was a patient who had presented with some weird psychiatric symptoms. And can you just tell us?
So this was a middle-aged male. He has been following with psychiatry OPD also, and was last following up in neurology OPD. So neurology, he was following with the symptoms of altered behavior, and then on routine investigations, blood glucose was around 42 milligram per deciliter, checked twice. So the important thing is that these patients are sometimes following for many years in psychiatry or neurology OPD with vague symptoms and complaints. And when we checked the blood glucose, it was low and insulin levels were high. So one thing was sure that something is producing insulin, which is causing hypoglycemia. And on routine ultrasound and dual phase CT abdomen, which seems to be the best modality, we were not able to pick up. And when we did a Dotanox, there was a clear-cut signal. And post-op patient is following since now couple of years with us and is doing very well.
See, we have operated patient, but what is important about insulinoma is that it is not continuously secreting the insulin.
Yes.
And that's why these patients are not picked up. By chance, if they get admitted and we do the blood sugar and then we realize. Otherwise, when many times for several years they even can be missed. Because whenever they have the problem, they go and they will recover, and they reach, by the time they reach to hospital doctor, then by that time this report becomes normal.
Very right, sir. Very right.
That is
Sometimes they have complained of like
Yes.
weight gain because of the hunger at the time of hypoglycemia.
Rather than most of the patients being treated in psychiatric department, so
Yes.
they should do screen the psychiatric patients.
Another, Dr. Malik, another
Dr.
slide.
Herman wants to make a point.
So, sir, regarding the first query regarding primary hyperparathyroidism or PE scan. So, primary hyperparathyroidism is the classic indication for say localizing a parathyroid adenoma and targeting it for surgery. In tertiary cases, it's difficult to localize, and as sir has already said that your decision to have a bilateral nephrectomy there, you don't need additional imaging except rare circumstances in which you fail even after surgery. Regarding insulinoma, sir, we get cases at times because these tumors are small. We get cases with equivocal CT or MRIs, negative CTs and MRIs, in which in a significant proportion of cases we are able to localize. So it's not only insulinoma, it can be a diffuse involvement of the pancreas, which is a beta cell hyperplasia or a celluloplastosis kind of picture, which is again clearly seen on a extended scan, which is difficult to, I don't think that can be done that on a CT or an MRI. So that is one picture which we frequently get, and then you have to decide that near total finger kind of a thing can be operated in such a setting. So in practice, when you find a challenging case, then these modalities can come into play. If you have clear cut focal lesion, like in this case, you are rightly saying that you may not need any extra effort to go ahead. But if you have operated, it is still persisting again. For a recurrent setting, also we recently had a case in which the patient had a persistent as well as a recurrent hypoglycemia after surgery for insulinoma. So those are also good settings for these scans.
So, just a comment on this. Even ultrasound is a very good model to pick up the insulinoma.
In our case, all the CT mixed, but ultrasound said that it is there.
Ultrasounds pick up very nicely, and US guided, you can easily, trained people can pick up US
No, that
guided.
literature is saying that your ultrasound is better than the.
Sir, it is in fact endoscopic ultrasound, which has a very good pickup. Not a simple transabdominal, endoscopic.
Yes.
No, हमने जो किया वो conventional पे किया.
That was picked up.
Okay.
That patient we operated, we could find a localized only on the ultrasound. In the CT they missed. But again, it depends upon the size.
Virender, we have any comments?
I think a smaller lesion maybe based on the ultrasound or CT or anything, the smaller lesion.
One point regarding ultrasound is pre-op USG also can localize, but for pre-op USG to locate the location of the insulinoma, you require some guidance that will save your operating time. You can also do it with venous sampling, pre-op USG also, but if you have data in hand, it will reduce your operative time.
It's the most important indication is when you are not able to see primarily on the CT scan, most of these tumors are sub-centimetric size and very high chance of.
See, in our experience, what we do, we get cases having USG negative, CT negative, MRI negative, everything negative. Still, the patient has high insulin. our referral, our institutes are mostly these are type of the patients. So then, in these cases, we definitely Rutanol or exiting as the imaging we can help in that.
I think in these situations we have to also keep one more entity in mind, that is beta cell hyperplasia without any adenoma. So, and that the surgical strategy will also change. You have to do more extensive breast penetrating surgery, more like comparison.
In this beta cell hyperplasia, sometimes you have to do this calcium stimulation test. I think very few centers are doing it. Dr. Deva has done a couple of these at AIMS in radiology department where you check the insulin levels, and you have to check the insulin levels coming up from gastroduodenal artery, splenic artery, and then you see from which segment the hyperinsulinism is there. It's a real difficult working of a case of beta cell hyperplasia or acidoblastosis, where biochemically the picture will be of hyperinsulinemia with hypoglycemia. So I think again the interventional radiology picture comes into play.
Simply intraoperative ultrasound, more preferably when we are operating on parathyroid adenoma. Intraoperative ultrasound is better in terms of localization because that characteristically differentiates between lymph node available at our center is ultrasound. We can go for intraoperative ultrasound.
For that you have need to open that. Nah. For that you need to open.
After opening localization.
So it is always better if you are doing without any intervention.
No, I think what we want, questioner want to say is that instead of venous sampling, all these very tedious procedures, but we could not be done, we have been not able to success. And I think that's the only way out in for this other. That's the point we want to make.
That's fine, but before that, if you are doing imaging and you get the idea, that will be even better.
That's a nuclear medicine point of view. Ultimately, we have to open and see where incident is.
No, I think our surgeons have now started sharing our nuclear medicine point of view. And at least at AIMS, I can share some data with you. We have analyzed almost the last 2000 EV scans that we have done, and 450 fluorophylline PETs that we have done. And we have evolved a very robust system where our surgeons actually one day prior to surgery they come to us. They see the scans on the console. We provide them the view. And with fluorophylline, I must say that we have been able to localize in the de novo setting. We have been able to localize the NATs almost in 95 to 97% of cases, which leaves a very minor gap for an error. And I think all surgeons who are doing parathyroid claims are quite happy with this. So they have now actually, to be truthful, stopped the use of intraoperative ultrasound.
That's what I'm saying. You being a luxury institute,
Yes.
you are getting everything in house, but maybe our premier institute PGM is not having any nuclear medicine facility. So for this, we have to give a common idea of certain things. Give them such an idea at the top of the institute. This is what you can do as a luxury care.
Agreed. Point well taken.
Has to be taken.
Well taken point.
But today we get these facilities quite easily, and to open neck and then try to find out where is the gland, I will not do it. I do a lot of parathyroid, but I want to go with a focused idea where to go. I don't want to explore whole neck just to look for one spot.
So preoperative diagnosis is clear.
No, but today is the era of the minimal invasive era. So we have to have, but I think that is most important aspect, one of the very important aspects.
Alright, so after a very productive discussion and excellent presentation, Dr. Dharmender, congratulations. So we'll move on to the next speaker now. That's Dr. Nitya Shah, who is going to speak on sentinel lymph node biopsy in breast cancer, a surgeon's approach. And to complement her, we have Dr. Neeraj, who is consultant at Army Hospital, RNR, New Delhi, and Dr. Sunita. Hello, ma'am. So, kindly join us on stage.
No, she can keep sitting there, they will join.
She is at better place.
So the topic given to me was sentinel lymph node biopsy in breast cancer, a surgeon's approach. But I have twisted it to sentinel lymph node biopsy in breast cancer multi-team approach. So we are basically three speakers, which all are involved in routine in sentinel lymph node biopsy. To start with, what is sentinel lymph node? We all are knowing, but residents are sitting here who are not having any idea about what it is that. So for them, I have prepared a few slides which are for basically introduction of the procedure. Sentinel lymph node is basically a regional lymph node that directly drains the lymph from the primary tumor. That is, it is the first node to receive lymph from the metastatic cells. Likewise, we can see here the primary tumor, vascular supply, and then the lymphatic drainage. This is the first tier lymph node, which we are talking about, sentinel lymph node. Then there are second tier and third tier. Why it is important? Because accurate lymph node staging is important for prognosis of the disease and for the treatment, regional treatment of the disease. There is no imaging modality which is accurate to detect the lymph node. We have imaging modalities to exactly tell us about tumor size and metastasis size, but not for the lymph node. And sentinel lymph node biopsy is quite reliable in this regard, which can screen our exuded lymph nodes and we can identify the macro and macrometastasis. Why we want to do the sentinel lymph node biopsy? Sentinel lymph node biopsy we want to do in those patients who have clinically negative axilla. that is N0 patients. And when we are doing axillary lymph node dissection in these patients on final HPR, we are seeing that 60 to 70% of the patients are having 0 out of, say, 18 lymph node, 20 lymph nodes. So basically we are doing injustice to the axilla, and it should not have been done, because axillary lymph node dissection is not free from any complications. There are morbidity associated with the axilla. What morbidity it can have? Because we have shoulder movements, basically sensory and motor components are there. There is limitation of shoulder movements, there is paresthesias, numbness of upper arm. There can be lymphedema in approximately 30% of the patients, and we put a drain after doing axilla. So hospital stay increases because of the drain. And overall, we have to examine from pathology point of view 15 to 20 lymph nodes which we are submitting to them, and versus 5 lymph nodes which we are submitting for the sentinel lymph node biopsy. So the smaller the number of lymph nodes, better the report we can expect from the pathologist. So overall, we can say that after doing sentinel lymph node biopsy, the patient had a better quality of life as compared to the axillary lymph node dissection. So we want to as we were talking initially, that around minimal invasion. So we are also going to do minimal invasion to the axilla. So we are de-escalating the axilla by doing the sentinel lymph node biopsy. What are the principles of doing sentinel lymph node biopsy? In any tumor, solid tumor, we don't have any efficient structured lymphatic drainage. And it all depends upon the peritumoral interstitial tissue, which is draining by the normal lymphatic channels. And when we are injecting the radiotracers in the peritumoral area or dermal, subdermal, periorbital areas also, they follow the normal lymphatic channels, and they are retained in the first lymph node encounter. And these are reaching there because of the macrophage action of the macrophage, which are entrapping and phagocytosing those radiotracers, which are lining in the sinusoid spaces of the lymph node. So here we can see that abnormal sentinel lymph node, we are able to see that these are the afferent channels, and the red part of this is the radiotracer which we are getting, and these are the sinusoid spaces. Main function of macrophages is to clear the effluent lymph node particulate matter. So when we should do the sentinel lymph node biopsy? This is the basic recommendations which are given by the ENM and the SNMI. Here, which is very clear, is T1 and T2 tumors, that is small tumors, and node negative tumors. In every age we can do, no matter patient is young or older. Obesity is also not a contraindication. Both sexes we can go for. DCIS with mastectomy. DCIS with mastectomy, I want to say that when we are doing mastectomy for DCIS patient, then we should do the sentinel lymph node biopsy. Because if there is any element of invasion in the final HPR, we may not be able to revisit the axilla. So if we are performing mastectomy with DCIS, we should go for the sentinel lymph node biopsy. Before new adjuvant systemic therapy, it is established. Multicentric, multifocal is controversial. T3, T4 tumor, we don't really recommend for big size tumors. DCIS without mastectomy is also again controversial. Suspicious in pectoral lymph nodes is again controversial. Pregnancy, obviously because of methylene blue, they say that it should not be done. Evaluation of internal memory lymph nodes, poor diagnostic exceeding prior axillary surgery. Inflammatory breast carcinoma is cleared short treatment. N2 disease and inflammatory breast carcinoma, these two are basically contraindication for the sentinel lymph node biopsy. So let's meet the team after these introductory slides. Basically, it is an art of doing the sentinel lymph node harvesting and localization and the report by the pathologist. It's a theme of nuclear medicine, surgical oncology and pathology. And there is a learning curve. It's not directly like I have seen and I can do. Basically, there needs a lot of coordination between the team colleagues. Individual specialists must gain confidence with the various steps of the procedure, and at the same time they should rely on each other's contribution to the entire process. how to do the SNMB. It usually, basically, we are using the dual approach. Dual approach means we are using the vital blue dye and we are using the radio tracers. The vital blue dye can be isosulfan blue and methylene blue. And among these two, basically at isosulfan blue and methylene blue, we prefer methylene blue because isosulfan blue is difficult to get, and there are some reactions which are more with the isosulfan blue. Radio tracers we can use preoperatively and intraoperatively. In preoperative settings, with this dual approach, we are having 98 to 99% success rate in identifying the sentinel lymph node biopsy. Sentinel lymph node. Lymphoscintigraphy is done preoperatively by the nuclear medicine colleague and in the department of nuclear medicine only. The radio-guided surgery and vital blue dye they are done in the surgical suite. So now I will request my nuclear medicine colleague to tell us all in detail about what radio tracers we are using and how they are doing, how is lymphoscintigraphy done, and about the cameras, SPECT, CT, etc. So he will highlight about an ideal video collide.
Thank you, ma'am. So, sentinel lymph node biopsy evolved from the era of using blue dye to radiocolloids and to the recent one, fluorescent. So, the procedure of using radiocolloid will, I'll cover this topic under the heading of radiopharmaceuticals, what all radiopharmaceuticals we can use, activity and volume to be used, and injection, technique of injections, and imaging, what all imaging we can do for localization of sentinel lymph node, and radioguided surgery. So, for radiopharmaceuticals, we have options of various radiocolloids, which include sulfur colloid, nanocolloid, most common, and the newer tracer, which is a receptor ligand type of tracer, which is Tillman receptor. Now, one important consideration is particle size. So, if we are choosing smaller particle size, there will be faster rate of migration of the radiocolloid from the site of injection to the sentinel lymph node, but simultaneously there will be lesser retention time in the sentinel lymph node. So, we will get a very small window of imaging the lymph node. If we are using larger polar particles, the migration to the lymph node will be slower, but the retention time will be higher. So, you will get a good enough amount of time for imaging. So, we have to get a balance between the two paradigms. So, ideal size of radiocolloids for sentinel lymph node will be 100 to 200 nanometer size. So, for this we can pass the radiocolloid preparation through millipore filter, which is a 0.22 micrometer size of filter, which will get a uniform particle size in the desired range. One important point here to emphasize, the success rate of visualization of sentinel lymph node doesn't depend upon particle size, only the dynamics changes. Now, injection, the activity of radio tracer, radioactivity will depend on the factor whether we are giving the injection in superficial location or deeper. If we are using superficial injection, will require a minimum activity of less than 1 MCI or up to 1 MCI. If we are planning to give deeper injection like peritumoral injection, we may require higher activity. Volume again, lesser volume for superficial injection and slightly higher volume for peritumoral oblique intraretinal injection. Now, one important point that colloid get settled in the syringe if we leave it here, as it is. So, before giving injection, we have to gently rotate the syringe. Single injection is generally preferred, but you can give multiple periareolar or peritumoral injections as well. After giving injection, you have to massage the site of injection to promote the movement of the radiochloride through lymphatics. Now, injection can be categorized into superficial location like intradermal, subcutaneous, subareolar, periareolar, and deep injection under peritumoral and intratumoral categories. Now, all the injection technique depends on the common physiology of lymphatic drainage, that all the most of the lymph nodes from breast parenchyma, including subcutaneous tissue over the breast, moves through a common pathway of subareolar plexus or leptis plexus to the axilla. So wherever you are giving injection like intradermal, periareolar, subareolar, it is moving to the same channel where the lymphatics from the whole of the breast is moving and finally going to the towards axilla. Now, injection in subdermal, there are pros and cons of all the techniques, but most center prefer periareolar injection. But the ideal one is combining the both techniques, giving superficial in the form of periareolar and deep injection in the form of peritumoral. Intratumoral injections are avoided because they are having chances of tumor seeding through the needle tract. Now, imaging part. After giving injection, we can do imaging on a plain gamma camera. We can do SPECT CT also. I will flash certain slides. So these are the images after giving silver albumin nanocolloid. So the first image we are seeing here, one site is the this one is the subareolar injection, and we can visualize the lymphatic along with 1 centimeter. In the second image, after giving one injection, we are seeing 2 lymphatic channels along with draining into 2 separate sentinel lymph nodes. In the third case, we are getting 3 lymphatics, but all draining into 2 collocated lymph nodes. In the last slide, there are multiple channels draining in almost 3 lymph nodes. So we consider all of them to be sentinel lymph nodes. Now, in the planar imaging, we are not able to visualize the body contour. We are not able to localize where all these structures are. So we can do body contouring also in case of planar imaging by a moving radioactive source. So these are the body contour imaging. This is the site of injection. This is the axilla, and we have done a body contouring by a moving cobalt source. So we can say that the lymph node localized is in the axilla and how far it is from the skin surface. So surgeon will get a rough idea where he has to look for. Now, this is the other method of doing body contouring, where we place a cobalt flood source in the table where the patient is being imaged. So it will also give you a body contouring. So to do the better localization and also to increase the contrast and spatial resolution, we also have option of SPECT, and furthermore, to add the information, we are having CT component with the SPECT. So this is the image of a volume rendered SPECT CT in the same patient where initial planar image was done. This was the injection site. This was one focus towards the parasternal side, another faint focus above that, and there was one faint focus in the axilla. But when we do SPECT CT, the volume rendered image shows this was the site of injection. This was one internal memory or parasternal lymph node. This was a second axonal lymph node just above the one, and the third one was exactly located in the axilla. If we corroborate all these findings with CT, so CT can exactly localize that the internal memory lymph node was in the second intercostal space, the axillary one was the level 1 axilla, and the upper one was a infraclavicular lymph node. And we can also measure the distance of the lymph node from the skin surface. We can also give measurement of the lymph node. That will be of great help for the surgeon. Now, handheld gamma probe, which is to be used in the intraoral setting. So after giving radiocolloid injection, we can also check the sentinel lymph node location by handheld gamma probe, which is based on the counts getting from the area of interest. So gamma probe are basically based on scintillation camera based, scintillation crystal based or semiconductor based. So the camera handheld gamma camera shown in the image the typical sodium iodide camera, which is calibrated with the technician window, and these are angled for getting useful in various locations like over skin surface and also inside the surgical cavity. They should be light, well balanced, and having all electrical safety consideration. So by using this probe, if we are finding any focus of radioactivity which is 2 to 3 times the background activity, we consider it the rays to be coming out from sentinel lymph node.
Neeraj, I think you can try to wind up.
Sir, these are the images where we are getting sentinel lymph node location pre-op, then intra-op along with the methylene blue dye. Then with the probe, we are getting the location, and after removal also we have to confirm that it was the sentinel lymph node containing the counts. Now few lines about the indocyanine green. We have shifted from blue dye to radiocolloid and now to indocyanine green. So indocyanine green is a water soluble green dye with infrared, near infrared fluorescent property. It absorbs light in range of 800 nanometer and emit in 830 nanometer. That is a very useful property where it can be utilized in the localization of sentinel lymph node. The only disadvantage with the ICG is the availability. It's not available at every center. Cost of the infrared device and cost of the indocyanine dye. The per vial dye cost is very high. And another important disadvantage is the ICG for use should be freshly prepared. If it is not freshly prepared, the sensitivity will be low in the range of 60 to 70%. Our institution is also doing a study on role of indocyanine in case of breast negative, node negative CFS. These are the images of indocyanine where we give a peritoneal injection. We localize this under the infrared camera. The lymph node shines beautifully, and after removal also we can see the fluorescence coming out of the now, what to do when we fail to visualize the sentinel lymph node? That is very rare. However, in 1 to 2% cases, we are not able to localize the sentinel lymph node. The reason may be old age, obesity, tumor location, multiple factors. But what to do when we don't visualize the lymph node? So, if we are not able to localize, and if the situations permit logistically, we ideally have to repeat the procedure of sentinel lymph node scintigraphy. And if we are not able to do that, then the answer is go with the axillary lymph node dissection.
Dr. Neeraj.
So after getting the information from our different medicine colleague, we take up the patient, or we can, if we don't have their help, then we can go per operative. Basically, before starting the surgery, the pre-medication room, we can start, we can give the injection. In this way, we get the syringes, and in the pre-medication room only, we can give the radioisotope, radio tracers, one basically superficial and one in the peritoneal area. This is a small video of around 1 minute where we are planning for BCS of the patient, and how this works is basically for the residents. This is the counter machine, and where it is giving us a maximum count, where we mark that point and give a very small incision around 2 centimeter, and we go layer by layer, and after identifying the blue node or any blue lymphatic channel, we reach up to that lymph node, and after getting up to that lymph node, blue color lymph node, we put the probe again, and we again see the counts on the machine, and as told by Dr. Neeraj, it should be 2 to 3 fold of the XY fat of the surrounding tissue and more than 10% of the XY fat. So we are again checking the counts. And we harvest that particular lymph node. They can be more than one lymph node also, but usually we take less than 5 lymph nodes. It should not be more than 5 lymph nodes actually. So as we are running short of the time, I will proceed to my slides. So after doing all this exercise, in brief, we can say that we are counting for we are putting our probe on the primary tumor, and we are again counting, putting the probe on the axilla, and where we get the maximum count, we put a small incision, and we are having 4 possibilities. Either it can be hot on the round of the gamma probe, it can be blue, or it can both be hot and blue, or it can be neither of these but just palpable lymph nodes. All these 4 situations are counting to the sentinel lymph node. Basically, how to define the sentinel lymph node is basically hot and blue, and palpable lymph node. So then we, after harvesting the lymph node, we give the specimen to the pathologist, and something Vana will tell about the lymph nodes, how they do the procedure with that.
So what we expect from the surgeon and what surgeon expects from us is in the next 2-3 slides. We expect at least 3 lymph nodes should be submitted for processing. And this processing is a frozen section if it is done intraoperatively. Other method can be that if we can do ultrasound guided good cytology FNAC, then that can also be done. But the best is paraffin embedded tissue that is examined by the pathologist. That is the best. But in that case, it has to be a second stage surgery if it is to be planned. So surgeon usually wants that we should give them the report at the frozen section. Now in the frozen section, what we do is we take the sections at 2 mm distance. Cuts are given at distance of 2 mm. If it is lymph node is less than 4 mm, then we cut it vertically. But if it is more than 4 mm, we give transverse sections. And minimum 3 depths are cut. Means 3 sections are taken from the lymph node. And we look for macro and micro metastasis on HND section. A rapid HND stain is done in the side room of the OT only. And if we think this is micro metastasis, sometimes we try IHC, but usually we do not do in the frozen. We keep this for the routine paraffin sections. And the important is that we do not use the whole section in the frozen. We keep some section for the paraffin embedded sections also, some tissue, because many times we are not able to find, but when we do the paraffin sections, we can see the tumor or isolated tumors cells in that. Now, so ideally, as I have told, the reliability of doing this for macrometastasis is at least more than 90%. If we do the imprint cytology at the same time, this also improves the harvesting or the result during the same time. While doing the frozen section, biopsy sections, we do the imprint cytology also, because this is simple and cheap, takes a few minutes. Tolerant blue, we put the tolerant blue, and within 2 minutes we can get the results. And there is no tissue loss also. And this also gives a reliability of around 95%. But this we will not be able to differentiate between micro and macro metastasis. So what is micrometastasis and what is macrometastasis? Macrometastasis is when the metastatic nodule is more than 2 mm. If it is between 0.2 to 2 mm, we call it as micrometastasis, and if it is less than 0.2 mm, then we call it isolated tumor cells. So finding isolated tumor cells in frozen section or in imprint is really a difficult task. So macro, micro or isolated tumor cells, these are the 3 things which we see, and then this tissue can also be given for nucleic acid testing. So what the surgeon expects from us, that what is the total number of lymph nodes which we have examined, and how many of these lymph nodes, sentinel lymph nodes, have metastatic carcinoma, what is the span of the metastatic largest focus, whether it is macro or micro, and what is the distance of this metastatic nodule from the capsule, or whether there is some extra capsular extension or some extra nodal extension is there, or whether isolated tumor cells are present. Then we have to, this is really difficult cut in frozen section if you have to do. That is basically on the IHC which we do further on in the paraffin sections that we can tell about the isolated tumor cells. Now, how do they interpret these results? Dr. Natasha will again check.
So finally, they have told us that how many lymph nodes we are having, which are positive or negative. So in form of results, what can be our future plan of action? If there is N0, N0 means, as Madam has told, N0 is less than micrometastasis, isolated tumor cells, which they are not giving on the basically frozen section. So if it is N0, central lymph node is free of macrometastasis, or there is macrometastasis. If there is N0, we will not go for the axillary lymph node dissection. If we are having limited N1 macrometastasis, like if we are having around 1 to 2 positive lymph nodes, even then we may avoid axillary lymph node dissection. If there is equal to 3 or more than 3 positive lymph nodes, or there is extranodal extension, or we are going for mastectomy, then we should go for the axillary lymph node dissection. So for us, PN1 is significant, and in that too, which is 3 or more than 3. There are ESCO guidelines, basically, which is N0 is no axillary lymph node dissection is required. The second guideline is, that is 2.1 is 1 or 2 lymph node positive, and if you are doing BCS and whole body radiotherapy, then there is no need for whole breast radiotherapy, then there is no need for doing the axillary lymph node dissection. 2.2 is 1 or 2 lymph node positive, but we are going for mastectomy, then we should go in the same setting, axillary lymph node dissection. Guideline number 3 is, if we are the patient is having DCIS and we are going for mastectomy, we should do the axillary lymph node dissection. Prior breast axillary surgery is there, we should go for axilla. And preoperative chemotherapy has been given, again we should go for axillary lymph node dissection. This is multifocal, then also axillary lymph node dissection. And guideline number 4 is T3, T4 tumor, inflammatory carcinoma of breast and pregnancy. Central lymph node biopsy is not done. There are lots of trials going on, like MROS trial, ACOSOS Z11. In MROS trial, basically, they are saying that if the lymph nodes are positive in the axilla, we can go for axillary radiotherapy also. Basically, we can avoid the axillary lymph node dissection, and we can just go for the axillary radiotherapy, and they are saying that their results are equal, and in fact, quality of life is even better in the MROS patients in that arm, which is using the radiotherapy instead of the axilla. So, basically, take-home messages, what is for the residents here, that it is a standard of care in the clinically node negative patient. We should do central lymph node biopsy in small tumor and lymph node negative patients. And to optimize the central node dissection, dual approach is preferred. And main goal is to detect the macrometastasis and not the micro. And it has a learning curve. It is not a single-day procedure like we have started and we are doing the best. To get this rate of success of around 98 to 99%, we must do in coordination around 40 to 50 patients in which we have done central lymph node biopsy. Then only we can attain this success results. Thank you very much.
Excellent presentation by both all three speakers. And I open the house for just 1 or 2 questions. We are running quite late. Just a couple of questions.
I would like to ask, as you told that your aim is to detect the macrometastasis, not the micrometastasis. What was my feeling was that it was a micrometastasis. Do you feel the outcome would be poorer if we don't do the ALNT and later on there would be recurrence of some sort of would be there, or that patient would be requiring any radiotherapy to the axilla?
Actually, outcome in macro, and if we compare the three, N0 is best, N1 mic is better than that, and N1 macro basically we are searching for. N1 mic, they are not revisiting the axilla, and they are giving the adjuvant systemic treatment which is already planned for the patient. That will take cover up that part also. So in N1 mic, we are not revisiting the axilla.
I have a couple of queries. One is, if you get multiple nodes in the internal memory or like the brain needle showed, so So what will be the approach in those cases?
Multiple lymph node per operative.
If you have sentinel lymph nodes in the internal memory station also or supraclavicular.
Actually, that is a different story. Actually, internal memory is there in less than 3% of the patients. It's come out with positive on particular lymphoscintigraphy and that particular area. But it's difficult to take the sentinel lymph node types of that part also, and that we expect that it can be taken care by the whole-breast radiotherapy, etc. Because to take biopsy from that area, there can be hemorrhage also, there can be pneumothorax also, and we expect that the same results can be there with the radiotherapy also.
Okay. Thank you. And second one query is, do you think that imaging is required before doing the biopsy with the probe? Because many of us are just
that is the best situation basically. Yeah. If we have LSD also with the peroperative gamma probe with the methadone, due to the best situation, but this luxury may not be available to all people.
Doctor, suppose T1, T2 patient and 0 Agila early lesion and we get a PET CT done, that also shows only solitary lesion in the breast. But they also says that there is the internal memory nodes. Should we do the central node or not in this patient?
Sir, staging of the basically TNM staging which you are talking of, like axilla alone, lymph node and internal memory alone, they are equal. If both are there, then the staging changes.
So in that scenario, there is no fun of going for the axillary lymph.
Yes.
Axillary lymph
Axilla
node.
should not be done.
So how many lymph node you take in a cell? Suppose 1, 2, 3 at a time. See, sentinel lymph node you have to take the first node.
Yeah.
But sometime when we are expecting that the disease may be there, so the lymph node are smaller, then in that case standard is 3 node.
Yes.
So what is your approach? What you do that?
So actually all the hot and blue lymph nodes should be out.
All the lymph node you take out. That doesn't matter number. Number
Sir,
doesn't.
it should be less than 5.
Okay.
Because if we will do more, then it will be equal to axilla lymph node section also.
No, as you said, the imaging will going to help you out. So why not do the sentinel lymph node in your nuclear medicine department and do a scan and do a specific scan like what we do in our hospital and from Rajiv Gandhi
We are
Cancer
not
Institute.
having any nuclear medicine department also.
So in our hospital, what we do in the morning time, 9 a.m., we inject the dye and then within half an hour to 1 hour we do the scan. And once we localize the sentinel lymph node, we take the SPECT CT scan and then the cross-sectional imaging is sent to the surgeon along with the patient. Then save a lot of time for him to identify the lymph node.
Obviously, this will save the peroperative time.
In AIMS, what we do the sentinel lymph node, we mark that area, and then we will send to the OT. They again inject and then they detect the flow, and that becomes so easier for them. I think, Praveen, you are not doing here?
So that is what.
No.
So we are planning to start with the period 1 case only, but with the we have already discussed and 1 to 2 cases posted also.
We are in the process of starting, sir.
Yeah, we are in the process of starting. We are getting the probe and will be starting. Yes, sir.
I think that is the problem, that is handicap. The center is not in the PA outside, and even it is not located in any hospital. We will try in the Kainal, but again the problem is there that it should be within the hospital. That is in-house.
In-house.
What is the role of ICG, autofluorescence?
And
So that's
yeah,
the
that is.
manipulation.
And what is they have answered that we cannot dispose of with the PET CT. Still, it is not that PET CT can be dispose of with the sentinel node.
See, the injection as you have given that contain only one millipede, as well as most of them you have injected in the syringe, you can take in the red sheet and go back, give back to the nuclear medicine facility. There should not be any issue of disposal. And the radiation exposure in this is almost negligible. No, even not countable, because we give 20 millicurie for bone scan, and here we are giving microcuries. So microcuries means it will not cause any damage, but nothing to the patient.
I think despite that permission will be required because it's
only
two separate facilities.
So logically, as such, ARP guidelines, there is nothing like that. Like, because if we are doing in a hospital setup, that is not possible. So even if like patients who are discharged, they have more radiation.
Agree, but does the ER?
Sir, I have no idea, sir.
I think
Which is why
you
better they should agree.
you can
So-
inject and send the patient.
Yeah.
You cannot carry the radioactive
No,
material. to
yeah,
the
that
other
is
side.
what we are planning to do, ma'am. We are planning to inject in our
They are
center.
very
Then mark that and then
minor amounts.
Yeah.
Inject, send the patient.
send the patient.
So my perspective is that start doing it. If ARB will say this is not allowed, then you stop that. Then you will say I was
Then
not
first stop the center and then.
Use the license.
Sir, now we have come to the.
Sir wanted to ask about
role
ICG.
of ICG.
Yes, that is important.
Sir, ICG, the initial results of ICG are as good as combination of dye plus radiochloride. The only problem with ICG is the availability, cost of the equipment, and thirdly, the cost per vial of ICG. It's very high.
How much it cost?
800 to 1000 per vial.
See?
So compared to this nuclear scan, will
Sir.
it work costlier or cheaper?
Costlier.
If they are replacing two agents and
Yes, sir, costlier, but in total it will be effective because the results are as good as combination of dye plus radiochloride.
No, you are telling only 800 per while.
Sir.
ICG.
Yes, sir.
How it is
So
possible?
Praveen, I think
Issue is even more issue is actually one more issue with the dye is that as soon as it will leak, it will contaminate entire the fluid. So in that scenario, you will not be able to pick the desired node. That is the problem with that. It is not the procedure with dye is not so easy. With sentinel lymph node, it will go to that particular node. It will not get leaked here and there. So the more practical issue is that if you will inject the dye, slightly if there is leak, the entire fluid will be blue. So in that scenario, you will not be able to do that.
so for further discussions, I think we can share Dr. Vivek and Dr. Shami's number with each other. Let's move on to the last part of today's CME. And this is basically session 4 on prostate cancer. So may I invite Dr. Shamim, Dr. Santosh Kumar and others.
We thank all our speakers and chairpersons for this wonderful session. Now moving on to our last session for the day, I would like to invite on stage Dr. Santosh Singh, Director and Urologist, Onyx Stones Hospital, Rohtak. Dr. V.S. Rathi, Professor Urology, PGIMS, Rohtak. Dr. Shamim Ahmed Shamim, and Dr. Vijendra Sangwan, Radiologist, Nirvana Diagnostic Center, Rohtak. Over to you, sir.
As you know, prostate cancer, management of prostate cancer is most controversial issue. It starts from the no treatment to aggressive rectal surgery, further external treatment, for metastasis tumor, hormonal treatment, chemotherapy, and now targeted therapy done by the radionuclear medicine department. Now I invite Dr. Bhupender Kabyan to tell us about immunology perspective of prostate cancer.
Good evening, Chairperson sir, faculty members and dear delegates. I would like to thank organizers of the Nuclear Medicine CME and especially Dr. Praveen Kundu for giving me an opportunity to be a part of this well-organized and a very informative CME. To start with, the topic given to me is carcinoma prostate. Basically, this carcinoma prostate is such a large and an exhaustive topic that it can cover a full conference of 3 days. So I have covered the major aspect of this. So to describe the prostate gland, it's accessory gland in males measuring approximately 15 to 20 grams with the borders, it's behind the pubic symphysis. Then laterally it lies on the levator majors and distally external sphincter. Then it is divided into 4 zones: peripheral zone, central zone, transition zone. So as you can see here, anteriorly it's behind the pubic bone, then below the bladder. Postally, it is adherent to the rectum, just separated by the fish of Denon Wheelers. And this chart is basically that revolves around our management of CA prostate. It's basically the testosterone that is secreted from the testis that acts on the prostatic cells and causes them to grow at a faster pace. So, on the basis of this chart, our androgen blockade depends. So the same where testosterone gets converted into dihydrotestosterone, and the medical management depends upon it. So it's the second most common cancer in men. The risk factors being the increasing age, ethnic origin, genetic disposal. Currently, there are no high-level evidence that preventative measures may reduce the risk of prostatic cancer. It is the sixth leading cause of cancer death among the men worldwide and second most common in the US. Estimated incidence in India as per the latest figures of 2020 is 41,532, and it is among the 5 top cancers in the male, with the genetic disposition of like BRCA1 gene, first degree relatives, and the Lynch syndrome. So for diagnostic evaluation, the initial what we urologists do routinely is the PSA. PSA when got introduced in 1990s, and subsequently it was approved by FDA in 1994. That led to dramatic detection of CA prostate cases, and that too are those which are indolent, silent cancers, which are limited to the prostate. So it's a mass screening or the population screening. It's a systematic examination of the asymptomatic men to identify individuals at risk, and usually initiated by health authorities. So it's mandatory in many countries, but not in India. So it's basically associated with increased diagnosis of prostatic cancer. Screening leads to detection of more localized disease and less advanced prostatic cancer. From the result of 5 randomized controlled trials, more than 341,000 men, no prostatic cancer specific survival benefit was observed. This was the main endpoint in all trials. So there was no overall survival benefit was observed. The foremost common is the digital rectal examination that it itself diagnoses in more number of the cases that whether the patient is having CA prostate or not. It itself detects 18% of the cases. So a suspected DRE in a patient with a PSA level of less than 2 nanogram has a positive predictive value of between 5 to 30%. Whereas abnormal DRE in conjunction with an elevated PSA more than doubles the risk of positive biopsy, that is around 48%. So what is PSA? It's a protein basically produced by the prostate. It can be in small but measurable quantities in a healthy man, and it's elevated in certain pathological conditions. The use of PSA, as I mentioned earlier, has revolutionized the prostatic cancer diagnosis. It's organ specific, but it's not cancer specific. Therefore, it may be elevated in certain conditions like BPH, prostatitis, and non-malignant conditions. As an independent variable, PSA is better predictor of cancer than either DRE or transrectal ultrasound. So there are no agreed standards that defines the measuring PSA. It's a continuous parameter with higher levels indicating greater likelihood of prostatic cancer. Many men may harbor prostatic cancer despite having low PSA levels.
So routinely the PSA levels less than 4 is considered normal. If it's more than 4, as I mentioned, never necessity that it's a cancer, but if the levels are between 4 to 10, there are chances that 25% of them will harbor cancer, and if it's more than 10, more than 50% will have prostatic cancer. So if the PSA is between 4 to 10, biopsy is indicated. That I will cover in the future slides. So a repeat PSA. When a repeat PSA should be done? A repeat PSA before prostatic biopsy in men with an initial PSA of 3 to 10 or 4 to 10, as some guidelines suggest, reduce the indications of biopsy in 16% of the men while missing 5%. A PSA interval of 3 weeks. That a 3 week should be an interval between the two PSA levels. And an early PSA, repeat PSA prior to disease of prostatic biopsy has prognostic information. So there are further few indicators like free to total PSA. Then free to total PSA is of no clinical use if the total serum is more than 10 nanograms per ml and during follow-up of non-prostatic cancer. Then there are few things like PSA density, PSA velocity, free PSA. I won't go much into detail. So this, as we can see from this slide, if the PSA levels, as we can see, as the PSA level increases, the risk of prostatic cancer increases. So these are the guidelines from the EUA that do not subject men to PSA without counseling them. Because if PSA levels are more, we might have to ask them to go for further tests, and ultimately it may come negative, but it has a mental and monetary burden on the patients. Offer an individual risk adapted strategy for early detection to a well-informed man and with at least 10 to 15 years of life expectancy. What about the patients at risk? Those are men above the age of 50 years, more than 45 years but with a family history of prostatic cancer. African Americans have more chances of having prostatic cancer, and men carrying BRCA2 mutations. Then the next thing that comes to our help is the prostatic biopsy. So when it should be done? When there is a raised PSA or an abnormal DRE. But should be avoided in prostatitis and prostatic tuberculosis, although we might have to do. So biopsy is the current gold standard to diagnose prostatic cancer. The only significant sampling error is that it detects less than 1% of the prostatic tissue. So there are higher chances that we may miss the real prostatic nodule or the prostatic cancer foci. So the present standards are when the PSA is more than 4, we should go for prostatic biopsy. And all these things are covered already. So indications of a repeat biopsy are when the first biopsy reports atypia, HGPIN, benign but clinical suspicion is high on DRE, and the repeat biopsy can be done on follow-up on the basis of when PSA velocity is increasing, when on the basis of free PSA, and if the DR findings are changing on follow-up. So again, when there is an initial negative biopsy, it can be in three conditions: that inflammation and prostate size when it is less than 25 grams, give a antibiotic for 4 weeks, then repeat PSA. If it's again less than 4, then routine follow-up. If it's again increasing above 4, then go for repeat biopsy. Same if initial negative biopsy or high-grade PIN, then also we can go for repeat biopsy. And one initial biopsy reports benign tissue, but repeat DRE suggestive of change findings and the PSA is increasing, then also we should go for a repeat biopsy. What are the contraindications for the biopsy? That is uncorrected coagulopathy, severe immunosuppression, painful anorectal conditions, and acute prostatitis. There are multiple methods for the same. That is the old one being the finger guided, routinely now done, nowadays also most commonly done. It's because of the lack of the training and lack of the infrastructure. Then the Doppler, transrectal ultrasound, 3D Doppler, power Doppler, MRI fusion biopsies, thrust fusion biopsies. Then there are other methods also like transperineal, because after APR we don't have any choice. Initially thrust was regarded as the best biopsy technique, but nowadays EUA guidelines are giving transperineal as the choice one prostatic biopsy technique. So very few urologists do their own thrust guided biopsy. Many of them have access to ultrasound machines but don't do thrust. But urologists should do, because they have the better concept of prostate anatomy and zones. So why not to do thrust biopsy themselves? So how many cores? It's again initially 6 cores, then 12 cores, extended, then saturation more than 20 cores, and as it's saying like only 25% of the chances when extended biopsy detects prostatic cancer. If it extended biopsy, then 40% chances. Same the impact of the prostate size. If the prostate size increases, there are higher chances of getting the prostate cancer detection. Same in case of extended biopsy. So what is indication prostatic biopsy? The chart explains the same, which I have already covered. So it's the first choice nowadays, that transperineal biopsy, because of the least chances of post-operative complications. And transrectal has come as the second choice. But initially it was avoided.
Please fast.
So few complications which routinely occur, that is hematostomia, hematuria, rectal bleeding, prostatitis, and the listed ones. So Gleason score, it comes under the domain of pathologist, that it's 5 grades, 1 to 5. And on the basis of this, ISUP also had devised their own grading system. So the RNM staging is used for diagnosis, the staging of the prostate cancer. Then there are different risk group based on 3 criteria, that is PSA, grading, and DRE. Then same ISUP grading has their own grading system. So recommendations is perform prostate biopsy using the transperineal approach. Due to low risk of infection, it is strongly recommended. Use routine surgical disinfection. Use rectal cleaning oil with COVID and iodine, that are strong recommendations. And ensure that prostate core biopsies from different sites are submitted separately for processing and pathological reporting. So now coming to the imaging, transrectal ultrasound and ultrasound-based techniques, the most commonly used to diagnose the case of BPH or a CA prostate. Then MRI, CT, colon PET CT, PSA, PSMA PET CT. So to diagnose the T staging, it's basically refers to the clinical T staging. It's only on the DRE finding. Transrectal ultrasound is no more accurate at predicting organ-confined disease than DRE. So T stage MRI, it's a two-weighted image. Imaging remains the most useful methods for local staging of MRI. Coming to the lymph node staging, CT scan and MRI both are used, but abdominal CT and T1, T2 weighted MRI indirectly assess nodal invasion by using LN diameter and morphology. CT and MRI have sensitivity in less than 40%, whereas detection of microscopic lymph node invasion is less than 1% of the cases. Diffusion weighted MRI may detect metastasis in normal sized nodes, but a negative MRI cannot rule out presence of lymph node metastasis. So Diffuse weighted MRI provides only modest improvement of lymph node staging over conventional staging. Then comes colon PET CT, which have a sensitivity of 62% and specificity of 92% respectively. Because of its low sensitivity, colon PET CT does not reach clinical acceptable diagnostic accuracy for detection of lymph node metastasis. So prostate specific membrane, that is PSMA waved PET CT, that uses 68 gallium labeled nuclear radio tracer that will be covered by the nuclear team. So it is found to have higher sensitivity and a comparable specificity for staging pre-op lymph node metastasis. It has a sensitivity of 77% and a specificity of 97%. So in summary, PSMA PET CT is more appropriate in lymph node staging as compared to MRI, as compared to CT or colon PET CT. How a small lymph nodes may be missed. And coming to the distant metastasis, that's bone scan, 99mm technetium bone scan. It's highly sensitive conventional imaging technique. It has a sensitivity of 79% and a specificity of 82%. The incidence of bone metastasis increases substantially with rising PSA and upgrading Gleason score. So bone scan should be performed in symptomatic patient independent of PSA levels, grading or clinical stage. Same fluoride PET and PET CT, colon PET CT, MRI, they also assess presence of bone metastasis. With the similar specificity and superior sensitivity to bone scintigraphy, it remains unclear whether colon PET CT is more sensitive than bone scan, but it has higher specificity. Only colon PET CT has the only advantage of detecting visceral and nodal metastasis.
Please conclude.
So these are the different recommendations. That do not use MRI as an initial screening tool. Perform MRI before prostatic biopsy. When MRI is positive, combine targeted and systemic biopsy. If MRI is negative, then omit biopsy based on the shared decisions making with the patient. So, coming to the survival, at 5 years, almost everyone with prostatic cancer is still alive. So no value of using 5-year stats to compare treatment protocols. Similarly, 85% of the cases that are diagnosed at local or the regional stage and their 5-year survival is close to 100%. 6% of the cases with metastasis, but even in this group 40% are alive at 5 years. So I won't be covering much of my treatment part here because it's very lengthy and exhaustive topic. So there are many new improved drugs, hormone therapies are coming up for the survival. So why is the management of prostatic cancer still controversial? Because many cases grow too slowly to affect the patient, so there is no justification to risk possible side effects of treatment in every case. And there is a need to understand the biology of the prostatic cancer to predict its behavior balance, that with the man's health, longevity, and the interest in considering therapy. Thank you.
Thank you, Dr. Sayan. It was a nice talk. We are lack of time and we will directly go to the next speaker. Dr. Hanan, please come. Okay, thank you. Because we have to go to Delhi. We do have to stay, we have to cover that distance also.
Thank you, chairpersons and the organizers for giving me this opportunity to be here. So I'll be talking about PSMA PET CT in prostate cancer moving forward. So imaging in prostate cancer includes anatomical imaging, transsectal ultrasound, multiparametric MR, and CT, as well as functional imaging, which includes the bone scan, which was the gold standard for detecting skeletal metastasis in prostate cancer, or multiple PET agents targeting different molecular pathways, including lipid metabolism, amino acid metabolism, DNA proliferation, and lately the PSMA PET CT. In the normal prostate, basically the lining epithelium around the ducts, they have a receptor, a molecule which is now called PSMA, which actually is a transmembrane protein with enzymatic activity. So it has been targeted, and radiolabeled peptides inhibitors have been designed to image and treat prostate cancer using this. So what ultimately we get is this kind of image in which basically you, in addition to the prostate, actually in the whole body scan we see other organs also, like the salivary glands, the lacrimal glands, some liver splenic activity, the renal activity, and the excretion. So it's not like organ specific like PSA, so it's different from PSA. So PSMA is a trans-2 membrane, type 2 transmembrane glycoprotein with glutamate carboxypeptidase activity, polyhydrolate activity. So it is involved in the cellular function, and higher levels of PSMA expression in prostate cancers, like they are associated with higher risk of spread to other organs. So it is significantly overexpressed in around 95% of the prostate cancer cells, with a 100 to 1,000-fold increase as compared to the normal prostatic tissue. And it is further increased in advanced stages of CA prostate and separation of androgen deprivation, and in metastatic castration-resistant cases. So these PSMA inhibitors have been made, and they bind to this extracellular domain, and they are internalized, leading to, and they can be used for diagnosis as well as therapy of prostate cancer. So these are two most commonly used PSMA radiotracers in India. So one is the gallium PSMA 11 or F18 PSMA 1007. So commercially available one is this F18 PSMA 1, which is commercially available just like FDG is available. So it does not have a renal excretion, so it gives us some inherent benefit that the urinary bladder activity is not there, and the prostatic lesion can be identified more easily as compared to the gallium PSMA, in which there is excretory activity in the urinary bladder. And we see normal physiological uptake in the lacrimals, the thyroid glands, the submandibular glands, some liver splenic activity from metabolism, and some amount of this laser is excreted into the intestines, and there is also expression of these receptors in the proximal small bowel, so that is also normally seen. So before going to the normal areas, one should know what are the normal areas. And this is a transaction section in the prostate region, in which we see that the urinary bladder activity is not there while the prostatic lesion is shining out. So normally we have to assess if we can quantify the degree of tracer uptake in the lesions in terms of SUV, or we can compare the uptake in the lesion to other reference sites in the body, like the liver or the thyroid glands. And higher the uptake, higher the score, it's likely to be malignant rather than benign pathology. So just showing you the findings in normal prostate or a BPH basically. Normally there is not a significantly high PSMA expression, while in some cases with prostatitis and sometimes low grade CS can have some low degree of PSMA expression. So if we see the cut section of prostate, so we can see different zones, the peripheral zone, transitional zone, and the central zone. So that is not easily, they cannot be differentiated on CT. So that can be done on MRI. But if we see on PSMA PET, we are able to make out the lesion. So we can say approximately it's the left peripheral zone for fibroblock position. You do not see the capsule. So MRI will be more accurate for T staging, but still you get approximate ideas, especially in cases in which you get a definite evidence of infiltration. In some cases, anteriorly located lesions can be detected on PSMA PET, which are in cases in which you have a negative transsectal biopsy. The small subcentimetric lymph nodes measuring even up to 4 or 5 mm can be picked on PSMA PET, improving the sensitivity of imaging overall. And many times bony lesions, even which are narrow lesions and which are lytic lesions, the PSMA PET tends to pick them up earlier. So MPMRI, we know that it can consist of multiple imaging, and it has a moderate specificity, and because of the complex interpretation using the finance criteria, the reproducibility is also not that good. So like in this case, this was a case in which the PSA was 11 and the MRI was suggestive of finance 3, and that was kind of equivocal, and in biopsy also initially target was done, there was no malignancy, but PSMA PET revealed a definite lesion in the prostate, which was proven to be a prostate carcinoma. This is another case in which the PSA was 5.5, the MRI was showing PARAS4, a definite lesion, but PSMA PET was negative, and the final diagnosis was prostatitis. So basically PSMA PET can help you to improve the accuracy of imaging, and in combination with MRI, it will give you the best results. So this is the algorithm for reporting of PSMA PET using which has been devised. So you can get you basically divide the prostate into 6 quadrants, 6 areas, and you can get a unifocal or multifocal involvement of both lobes. Semivesical involvement, the bladder involvement, or the rectal involvement can be seen. Small nodes can be seen. Oligo or distinct metastatic disease involving the lungs, liver, bone, whatever. All the sites can be seen. Although sensitivity may vary a bit in soft tissue metastasis. So initially the appropriate use criteria were given for PSMA PET in prostate cancer, and it was considered that it is an appropriate imaging modality in newly diagnosed, unfavorable, intermediate risk, or to high risk or very high risk prostate cancer cases. So you have a T2B or higher lesion, PSA of more than 10, and you have a Gleason score, 4+3 Gleason score. So you, in that staging in those cases, it's a good modality. Similarly, it's appropriate to use PSMA PET for detecting bilateral recurrence after radical prostatectomy or radiation therapy. So this was one meta-analysis which was done by our center, in which we evaluated the role of PSMA PET-CT to detect prostate cancer in cases of suspected prostate cancer, and it was concluded that the gallium PSMA PET on the basis of available literature has excellent sensitivity and negative likelihood ratio for the initial diagnosis of prostate cancer in patients who have a suspicion. And after this, a good trial was published, a prospective trial was published, in which they aimed to study whether the combination of PSMA PET with MRI was superior to MRI alone to detect clinically significant prostate cancer. And they showed that the PSMA plus MRI improved the negative predictive value and its sensitivity to 90% for clinically significant prostate cancer in an MRI trial population. And they also gave a scoring system to interpret PSMA PET-CT. Regarding staging, this was one of the big trials, prospective trials, which was done, the PRO-BSMS trial. So they had around 302 patients, in which they showed that the overall accuracy of PSMA PET was 92% compared to for staging. So compared to 65% for CT plus bone scan for soft tissue and bone staging. And it overall had a greater impact on the management as compared to just conventional CT and bone scan imaging, and less equivocal results. So it established that the PSMA PET-CT is a better modality for staging of intermediate to high risk prostate cancer patients. Regarding lymph node detection, the overall accuracy of PSMA PET, the sensitivity is around 60%, the specificity is around 94%, but still it cannot replace like pelvic lymph node dissection. Regarding biochemical recurrence, basically it has one of the highest detection rates across different ranges of PSA levels. And in this context, it has been reported that the F18 PSMA outperforms gallium PSMA because of less urinary excretion, and it leads to a change in management in a significant percentage of cases. So PSMA PET is also used for selection of patients with metastatic castration-resistant prostate cancer for PSMA-based therapies using lutetium or actinium, and trials have been published which show better overall results as compared to standard of care. And like bone disease, And many bone diseases no one measurable on CT as per this criteria. And PSMA PET basically can be used to measure the activity of bone lesions and can be used to measure the overall volume of the disease. And a new response condition criteria using PSMA PET have also been found. And this is one new type of prostate biopsy actually which has been innovated in PGH and liver. So basically we are targeting the prostate cancer in cases with negative transsectal biopsy and high suspicion using a transluteal approach which has been published and which has been proven to be very safe and with no risk of infection. But there are limitations. So false negatives can occur because 5% of the prostate cancers do not express PSMA and there is a moderate accuracy for lymph node detection. And false positive have been seen to some extent in inflammatory conditions, and PSMA can also show uptake in neovasculature of other tumors. So if you get a finding which is not expected in a case of CA prostate, then a possibility of some other benign or malignant neoplasm can also be there. So to summarize, PSMA imaging has high diagnostic accuracy in prostate cancer, including suspected prostate cancer, especially in cases in which there is equivocal MPMRI, negative biopsy, but still strong suspicion. It can also be used to guide the biopsy. It is recommended by NCCN for staging in intermediate to high risk of prostate cancer. It leads to less equivocal findings and impacts the management. It has highest detection rates in biochemical recurrent prostate cancer. It can be used to evaluate response in systemic therapies, and it can actually measure the non-measurable lesions of CT and selections of patients for PSMA radioligand therapy. So the current NCCN guidelines for prostate cancer, they have included PSMA PET CT, and it is a potential one-stop shop for prostate cancer imaging. Thank you.
Very nice. I have one question. Can we routinely advise PET PMSA scan before biopsy, prostate biopsy?
Oh, so sir, we have experience over the last 5-10 years, and actually right now one of the most common indications for which we are getting these scans is for initial diagnosis only, and we do biopsies also in those cases. So there was less, at least a couple of years back there was no consensus. So we used to say it is useful, but most people used to say it is not useful. But after that, more and more studies have come, and the primary trial has been concluded, which has shown that overall it improves the over-detection to a rate which is like more than 90%, and it is better. But how it impacts the survival, how these earlier detections impact survival, this we don't know.
Area most involved from there that we can get the biopsy.
I think to start with, like if you have a case in which NPMRI couldn't be done, so or NPMRI is inconclusive, or MRI is definite, but you are not getting the cancer on the biopsies. So the difficult cases can be the one in which one can begin to try to use it.
And this is for diagnostic purpose.
I think Harmandeep, what you have already shown in your, slide, the primary trial. The primary trial is a combination of PSMA and the MRI. And it clearly shows that combination has improved the negative predictive value to 97%. So if you have both MRI and PSMA negative, then you can avoid your trust. The chances of missing the high grade malignancy is only 3%. So that is the take.
There was one very,
and more than that, this is we are talking about the primary classification and primary diagnosis, and there is no answer in other modalities like the nodal metastasis, distant metastasis. The PSMA is the best diagnostic modality as of now.
See, no, question was, he asked the question whether we should do before biopsy. Issue is that what I feel or what I think that it is a modality not for diagnosis based metastatic workup primarily, but in cases where it is PR is low, PSA is high but rectal examination is normal, then of course we have to localize and this thing. That way it will be better or better.
Only selected case only.
So that's where we started actually. DRE negative.
That's where it is role is. Otherwise, main role is metastatic.
Yeah, sir. Sir, with PET MR, which is going to come in the market and already available in some centers,
so then it is going to replace the MRI which we are doing immediately, and then we are doing PSMS, and then PET MRI will take
Will
over.
be the main staging modality.
Yes, that will be the investigation of choice in that case.
And metastatic and diagnostic modality when it is unknown or we are not able to say what is it, biometric chemical marker are high, but
Other investigations, which he has already mentioned, that when we have a equivocal finding on the conventional imaging, then we can do it. So Dr. Harman, nice presentation. Next time Dr. Khalil को हम बोलेंगे कि अगर कोई शॉर्ट और टाइम पे प्रेजेंटेशन खत्म करना है, उसके लिए कोई अवार्ड देना है, तो we will give to the Harman. और अगर किसी को फाइन करना और पनिश करना है तो डॉक्टर दामले और मेरे को करेंगे. So anyway, next time we will be careful in this type of award. We will keep some time. So it was डॉक्टर जो हमारे यूरोलॉजिस्ट थे वो कहाँ चले गए, उनसे भी एक क्वेश्चन पूछे.
सुनो, आप अपनी पनिशमेंट मेरे ऊपर मत डालना.
देखो मैं अकेला नहीं पनिश हो जाता, इसलिए आपको लिया है.
डॉक्टर शमी में एक चीज जो हम लोगों का भी आई थिंक डॉक्टर हरमनदीप ने भी मेंशन किया है, दो द PSMA PET scan is there, but we still don't know the long term outcome effect of the PSMA PET scan, whether it is impact the survivor or not. So that's why even if you read the NCCN guideline correctly, it says that the PSMA is equally effective with the conventional imaging, but the long term impact on the overall survival we still don't know.
वो आ जाएगा ना, उसके लिए आना है. एक चीज मैं यूरोलॉजिस्ट से पूछना चाह रहा हूँ, यूरोलॉजिस्ट यहाँ पे. अरे सारी सारी यूरोलॉजिस्ट. जैसे आपने you must have heard that Angelina Jolie, some Bollywood and Hollywood actress has gone for prophylactic mastectomy.
Bilateral.
Prophylactic mastectomy. I don't know the name of that actress, but I heard that. So my question to you, urologist, that why can't be a prophylactic prostatectomy? So it will avoid many complications, and it will avoid doing this all investigations and therapies and all.
How many organs you will remove? How many organs you will remove then?
Because we can't say
Anything.
and after you are killed, you remove the prostate again.
No. Why?
It is also age related for them. If patient has been a person having 100 year age, incidence is more higher than the 50 years, 60 years.
But I think the important is the clinical significant prostate cancer. That's why even the PSA screening is is in the question. So if it is not clinically significant, it is not affecting the long term survival, there is no point of identifying it.
Now robotic surgery.
This is a lighter mode question. I was just.
No, it is good. You have quite a good thing that it is era of the robotic surgery, and the time will come that we do the PSA after 50 at the age of 50, and if it is positive, then take out the prostate. Or even if it is not positive, then after 50 one can take out, because it is quite safe to do prostatectomy by robotic.
Sir, my point is also that why to keep this inside when this is going to be a problem. 1 in 7 male, this problem is going to come.
So there are many complications of the surgeries as well.
Yeah, I can understand that the most important complication is breathing. That's why I asked the urologist. Otherwise, I was going to talk.
Demand and supply is the most important factor. Moment the surgeons start training for robotic, then they will finding the work, and that's the way it is going to come soon.
That will benefit them, na? That will benefit their workload will increase, their income will increase.
So no, I think you can start by setting an example.
See, I'm ready for that. You know why I have asked this question? I have asked this question for this better only. I will get a better answer and then I will go for the prostatectomy.
Only aim is to detect the cancer there earliest and go for robotic surgery. Even you diagnose the prostate cancer at the age of 50, but listener still is 6 or less than 6. You can't do surgery. You have to wait. That is active surveillance.
I think Dr. Shamim, in your presentation also you said the reproductive system is your favorite system, even from the
See, this the function of the prostate is not required now.
I think we have to show some respect to the chairperson, so let us go on.
So you should respect me. You should not talk
So Dr. Shamim sir has done what he does best actually. He's one of the best person who best sense of humor actually. I think all of us who know sir they agree. And Ruby ma'am, I think in the morning she experienced this first hand when she was missing and she was not standing for his session and she was standing for Dr. Damle's session. So ma'am, you can just make out like. Anyways, I think everyone is so awake, and now we are coming to the last part of our CME.
So, sir, now we call our other panelists.
Yes.
देखो हम लोगों को यहाँ बैठने की आदत इतनी कर दी है प्रवीण आप भूल ही गए कि हमारा काम खत्म हो गया है नेक्स्ट पैनलिस्ट इज डॉक्टर
So,
Dr. Ashwini and always young
Dr. Sunita Singh ma'am,
he is not ready to become old. I have seen him since many years. I will
Dr. Harmeet Singh please,
Dr. Harmeet और प्रवीण
Dr. Manoj Gupta,
अच्छा मैंने भूल गया दो आदमी का मुझे बोला था सॉरी इन्होंने मेरा नाम नाम पे लिया
Dr. Abhishek Soni.
मेरा नाम हो गया ना
अभी जगह नहीं है
And our moderator Dr. Praveen Kurlu.
So, good evening everyone. I think everyone is quite awake after the main session. And because of our urologist, Dr. Bhupendra Kadyan sir, and excellent lecture by Harman, my job is very easy. So, I'll just be taking a very brief overview and we'll try to wrap it up within 50 to 20 minutes. So that is our target. Because ma'am has to leave, she has already postponed her timing multiple times. So thank you everyone for coming and staying for this session, and they have not cancelled. So first of all, I'm really thankful for this team. Thank you so much, thank you everyone. So starting with the prostate cancer, we have been talking till now very detail, starting from the FDG, from the thyroid, which is for last many years is our rosy roti for the nuclear medicine people. But lastly, we are coming to which nowadays we have kind of becoming our very favorite topic, and we are trying to be expert in that. That is prostate cancer. So in this next 20-25 minutes, we'll be just taking a brief overview of prostate diagnostics, starting from the initial diagnosis till the treatment part, and where as a nuclear medicine fraternity we are pitching in. So starting with the thing, as our urologist told us, the basic thing is when we are approaching a prostate cancer suspicious case, we start with the initial T-staging, ultrasound, MRI, PSA, and Gleason grade score. So coming to the most important thing where we are doing the prostate cancer biopsy. So first question to the ma'am. So what is exactly adequate core biopsy sample?
I think Dr. Kadyan had told that minimum 12 should be there, but if it's good, it can be 24 cores can be there. But even if with 12 cores, we can miss 20% of positive cases, and even the scoring, 20 to 30% of cases, Gleason scoring can be misinterpreted with 12 cores. So ideally it should be 24, but I think getting 24 is difficult. So somewhere more than 12 cores should be there.
Okay, and as we have seen, this stratification, the core biopsy, the number of core biopsies positive and the Gleason rate, that is a very important marker. Ma'am, if we are doing more and more imaging-based guided biopsies, as Dr. Herman also pointed out in the PSA obesity guided biopsies or ultrasound guided biopsies, those are being done routinely in all the tertiary centers. So will that impact our Gleason score, Gleason rate?
I think even we do PET biopsy or something MRI, I think scoring is needed because for risk stratification, that which are the cases which are going to metastasize. Yeah. We need the Gleason scoring and the group grading. Like for low risk, we say if it is initially it was only the Gleason score. Yeah. Like Dr. Sanjeev was telling, it is very confusing. You write 3 plus 4, 4 plus 3, 5. So yeah. Now to help surgeon, this score has now been changed to grade, group grade 1, 2, 3, 4, depending on the score only. Group grade 1, we say it's a very low risk. Grade 2 is low, 1 to 2 is low risk, where the 2 and 3 is intermediate, and grade 4 and 5, it is high risk, where there are high chances that the patient may go on to develop metastasis.
Yeah, definitely. So Gleason grade score, Gleason score grade, and as well as the core biopsies, core residents who are sitting here, and I'm really happy to see so many residents sitting here. The core biopsy, the number of core biopsy positive, that makes a very important prognostic factor for the risk stratification, dividing unfavorable and favorable risk factor and very high risk factor, high risk stratification for the prostate cancer.
Just 1 minute. Addition to this is also important that how many cores are positive and how much percentage of those cores is there. That is what we write in report also, that out of 12 pores, only 4 are showing, 3 are showing, and what is the total volume which is showing the cancer, presence of cancer.
Yeah, even the
So that
grade
is also
yeah.
helps in the risk stratification.
Yeah, that's right. As like we have concluded, the very high risk and high risk if greater than 4 cores are positive, and or greater than 4 cores with 4 or 5 genes in grade is positive. So that is very high high risk for the this prostate cancer. So so coming next to the sir, this Dr. Santosh sir, we have been discussing regarding conventional imaging, which we have been using till now because of the many factors, because nuclear medicine was not easily available or whatsoever reason. So do we still use our conventional imaging, bone scan, CT scan, or we have moved to PSMA PET-CT for the cases where intermediate risk is there, like as per our stratification, or we are still using say conventional imaging. So what is your practice, sir?
After diagnosis, depend on the biopsy report. If Gleason grade, Gleason score is less than 6 or 6, above 7, we plan surgery. With 6 or less than 6, we keep patient on surveillance.
Okay.
So initially PSMA score was not available. So before going to put that, we see the MAT. Where is the MAT? So initially bone scan was the recommended treatment. But now after coming to PMSA scan, we shifted to PSMA score for any MAT other than prostate itself. And if it is localized in itself in the prostate, Gleason scoring is 6 or less, we put patient on surveillance. If patient age is less and actively present. That is the protocol. If more than 7,
PSA also, if the PSA is more than 20 only, then bone scan was recommended.
Yeah, all that was for the initial.
But nowadays it is preferable because it has the metastasis elsewhere also.
Yes.
PSM is preferable.
So we go for the PSM scan. So if I have to summarize the recent guidelines in the one sentence which Dr. Manoj sir also mentioned, in NCCN guidelines, the recent most guidance session they have concluded, PSMA PET-CT, PSMA PET-CT, MRI, bone scan or conventional imaging is not a prerequisite for doing a PSMA PET-CT. So that PSMA PET-CT is equally effective, if not more effective. And this is if we use the appropriate usage criteria, then from the unfavorable intermediate to onwards, they are recommending PSMA PET-CT. So this is one example actually where we are showing. Yeah.
One more thing, I think if we are doing a PSMA PET scan and if we are avoiding a bone scan and a CT scan, we are giving much less radiation to the
Yeah, exactly, sir.
That is again important.
Yeah, that is exactly, and in this case, like we are, this grade is 3, but PSA is 63.5, so our risk is high, and in this patient, it was like the patient had oligometastasis, multiple bone metastasis were shown, because sensitivity is very high, and as the pro-PSMA trial also showed, it changes management also. The sensitivity is high and changes management also. So coming to the next topic, sir, if patient is in this after PSMA PET-CT, patient is clinically localized. So then how do we proceed for the treatment part? Like in this example, this was a like 76-year-old male, initially Pirates 5, but PSA was very high. See, this is the beauty of PSMA PET-CT, Pirates 5 PSMA very high. Still, it was localized disease, though it was locally advanced disease. So in this kind of patients, sir, how do we proceed, sir? Like if we come to all this, sir.
in this case, patient you have a localized prostate cancer and Gleason score is 8, so it is more than 7. So we go for the definite treatment, that is radical prostate. Either it's a conventional type or now there is a robotic type. Advantage of robotic type, disadvantage of conventional treatment is there is high incidence of incontinence of urine.
Okay.
It persists for 6 to 9 months. And in some patients also having erectile dysfunctions.
Yes,
These are the major complications.
Yes,
Other like rectal injury and stenosis, these are the minor that can be tackled.
Yes, sir. So coming to our radiotherapist from the panel, sir,
No,
Dr. Abhishek,
that's
sir.
just it. So now comes robot. Now in robotic surgery, at least one side doing the nerve sparing rectal prostatectomy.
Yes, so that
in
is
that condition, incontinence part is also covered, erectile dysfunction part is many part can be covered and may be treated by the sildenafil or tadalafil.
Okay. Sir, in this, I think radiotherapist would like to go for
Radiotherapy. So sir, what is your normal practice in this kind of patients?
As far as the long-term outcomes are concerned,
Yeah.
surgery has got around 70 to 80%, I think, 10 years survival. The radiation is having equivalent results in terms of overall survival and recurrence-free survival. Biochemical relapse are less. And the second common thing is the toxicity is very less. The surgery-related morbidity is more in after RP, and if we go for radiation, they are very less.
So
and equivalent other, we can say that in low risk, intermediate, and high risk, they are having around 85% to 80 to 85% results are there.
In the long term, sir, you're rightly pointing out in the long.
One pre-question, if we patient underwent radiotherapy, then it is very difficult for surgery later on.
Yes, sir. That is true. That is true, sir.
I think this is a T4 lesion. So we are looking
Sir,
for the
yeah,
grade
T4,
of
sir, that was
T4 lesion.
clinically localized, sir. We have I have summarized T2, T3 intermediate.
The surgery is the best
scenario,
for localized. Surgery is the best.
Yeah, I think sir, as a that is a very debatable topic, but as a neutral person who doesn't know much about the surgery or radiotherapy, but what I have
Previously, RT was given in conventional doses like 2 gray per fraction for you can say for 2 months.
Yeah.
But nowadays, hypofractionated RT is given 6 to 7 fractions, 40 to 42.
Yeah.
Just 7.
So that is decreasing the side effects, but as per NCC, and if we have to conclude, so they are concluding, if I'm right, they are concluding over the long term, no major outcome difference. So I think it will depend much on the patient preference as well as on the surgeon, high volume, and so many factors. So here even in the clinically localized, there is one more topic which I would like to touch. The role of ADT. Even here in these patients, so how do we proceed with the ADT part, sir, in these patients?
In this localized patient, there is no role of ADT. It is only indicated in hormonal metastatic disease.
Okay. So
stage 2 and T2 we only direct the procedure is enough, and patient should be on follow-up in 6 monthly PSA.
Sir,
Then
Dr.
there is a writing trend, a positive marking, then go for the radiotherapy in other part.
Okay. Dr. Hamid, sir, would you like to add anything?
ADT is given in all the cases of prostate cancer. In low intermediate grade, we can use for 6 months, 4 to 6 months. But usually we get high grade tumors or locally advanced or metastatic tumors. So in that cases we have to use 2 to 3 years of
Yeah, so that is, sir, I think this is also one thing, like for the short term and the long term, that is also very personalized decision. ADT, for how long do we need to give?
In any patient, T4 stage or any patient, role is only for 3 years. After that, it is different occurs, the resistance occurs, and there is mutation in the receptor. So many times for ADT, patient deteriorate, and stop the ADT, patient improve. That is a receptor mutation.
Yes,
So after 3 years, there is no role of ADT in any cases.
Okay, sir. So, sir, you are adding something?
Yeah, mostly we can use pulsed ADT.
Okay.
It will improve the cardiovascular function and also it improves the sexual function of the patients.
So, Dr. Abhishek, sir, in this cases, when patient is like presenting with a clinically localized disease, do we using brachytherapy also?
Brachytherapy may be given, but that is given in combination with RT.
Okay.
Not as
Not standalone.
Monotherapy as monotherapy may be given in very low risk cases.
Very low risk. Okay, in intermediate risk, we don't use that. Okay. So now coming to our next scenario, that is a patient is presenting with regional and metastatic disease. As was this case, patient had PSA with intermediate risk, but patient presented with the multiple standard metastasis as well as multiple pelvic lymph nodes. So this is again highlighting PSMA PET-CT, how it is upstaging even with the PSA value where it is 70. So in these patients, Harmeet sir, how would you like to proceed ahead? This patient is already in the case, patient is presenting de novo metastatic hormone sensitive prostate cancer. So what is